Welcome everyone. My name is Emma Suggett and I'm a pharmacist working for the West Midlands Academic Health Science Network, or AHSN. Thank you for taking the time to view this video. There are 15 AHSNs in England, which are organisations commissioned by NHSEI to support the implementation and adoption of innovation into the NHS. Transfer of Care Around Medicines, or TCAM, is just one of the many projects and innovations we are commissioned to deliver nationally. So I spent the last 2 years supporting systems in getting this e-referral pathway up and running. This video is to articulate to stakeholders how the new Discharge Medicines Service for community pharmacy relates to TCAM and what will be expected of contractors in the West Midlands. There is now a large amount of evidence nationally that those patients identified by hospital pharmacy teams as requiring additional support with their medicines benefit from a conversation with their community pharmacy when information is referred electronically. Those patients can then be supported by their pharmacist in the weeks following discharge to reduce the likelihood that they are readmitted due to a medicines-related issue. This e-referral pathway is known as Transfer of Care Around Medicines, or TCAM. From the 15th of February, TCAM will launch in community pharmacy as the Discharge Medicines Service, a new essential service which in the main will be synonymous with TCAM. It'll be delivered across the West Midlands, mainly using the Pharm Outcomes platform. This video will outline some of the key aspects of the service which are pertinent to community pharmacy. So just to warn you what we'll be covering over the next 15 minutes or so, we'll cover why the service is required and what it's trying to achieve, what training community pharmacy staff will require to undertake the service, what referrals might look like and what sort of patients might be referred, details of patients and how many referrals you're likely to receive. Finally, I've included some useful links which will be available through this slide set, which I've circulated for posting on your local LPC website. There have been numerous studies published, all of which show positive outcomes for patients through TCAM. The main benefits being associated with a reduction in readmission rates and decreased length of stay. However, it's important to note that all studies only demonstrate these benefits in patients followed up by the community pharmacist, compared with patients who were referred but were not given this support. So this is not just about sending information across the interface, but it's about those face-to-face or telephone conversations with patients which consistently demonstrate a benefit. Elderly patients have been shown in particular to benefit from the service, but there's never been a true consensus based on research regarding which patients should be referred and who should not. Referrals are in the main subjective and left to the professional judgment of secondary care pharmacy teams. There are additional benefits to community pharmacy born from the sharing of information across the interface, and if you have the time, I would suggest that you watch this YouTube video at the link on this slide, which details some of those benefits which were recorded for us in the Midlands. The underlying principles of the DMS are to support the patient's understanding of the medicines using the principles of shared decision making, with a view to reducing harm at the point of transfer of care between settings. This reduction of harm will in turn reduce readmissions. A significant benefit of this service, however, will be to support information sharing between different pharmacy sectors, a key enabler as we move towards integrated care. So what do you need to do to prepare? Contractors will need to ensure relevant staff, including pharmacists and pharmacy technicians, who will be involved in providing the service, have the necessary knowledge and competence to undertake it safely. As a minimum, pharmacists and pharmacy technicians providing the service should read the section on DMS within the NHSEI guidance on the regulations. I've provided the link here and on the final slide of this presentation, but it's the chapter 8 which you really need to read. Secondly, there is a new NHSEI DMS toolkit which is available on their website and contains a detailed overview of the service, not only outlining the expectations of community pharmacy, but also secondary care teams, PCNs and GPs. So I suggest that you have a read. Additionally, it is recommended that community pharmacy staff also complete the CPPA NHS Discharge Medicines Service e-learning and assessment. Again, I've included the link on my final slide. Once a pharmacist or pharmacy technician has undergone the appropriate training, they must complete the DMS Declaration of Competence on the CPPE website, in the same way that you would record a declaration for any other service such as smoking cessation, etc., and provide a copy of that competence to the pharmacy contractor. The link is here. Other members of staff that will play a part in supporting the provision of the service should be briefed on the service, with appropriate training provided for any roles that they will play. This document is available on the PSNC website and can be used in briefing sessions for pharmacy team members. There's also another briefing document on the same website for GPs and PCNs should you need to access one. NHS Trust will identify patients who will benefit from the DMS, and subject to the patient consenting to a referral, they'll send the referral to the pharmacy via a secure electronic system. In practice, that might be Refer to Pharmacy app, Farm Outcomes, or NHS Mail. The following information should be included as a minimum: the demographics and contact details of the person and their registered general practitioner, including their NHS number and their hospital medical record number, the medicines being used by the patient at discharge, including the name, strength, form, dose, timing, frequency, and planned duration of treatment, and the reason for prescribing, how the medicines are taken and what they're being taken for, changes to medicine, including medicines started or stopped. Contact details should also be provided for the referring clinician or hospital department, so that if there is a query, you can contact the pharmacy department. So the next thing to consider is which hospitals might send you referrals in the West Midlands. All the hospitals who are live with TCAM in the West Midlands are live with Farm Outcomes. Nationally, almost 50% of acute trusts who now refer to through TCAM on discharge are using the system, the TCAM system, and over 99% of these also use Farm Outcomes. This is, if you didn't know, this is the same platform which is used for the Community Pharmacy Consultation Service by NHS 111 and GPs, and for the documentation of NMS and flu services. So the situation in the West Midlands pretty much reflects the national picture, with the addition that we have not limited TCAM to acute trusts and have a couple of community trusts who are also live. This map shows our 13 live sites, all of which are using Farm Outcomes. Currently, trusts are limited to referral to pharmacies within their locality, but from the 15th of February, they can refer to any community pharmacy in the whole of England who use Farm Outcomes. It's therefore possible, particularly if you're on a regional border, that you could receive a referral from a hospital outside the region. However, all trusts using Farm Outcomes will make referrals using the same standards, and contractors will be paid in the same way, irrespective of where the referral originates from. What might cause more of an issue are those trusts who are not yet live with Farm Outcomes, who have made a decision not to use Farm Outcomes. In terms of acute trusts who've yet to engage, mainly these are ones in Birmingham, Solihull, STP. These trusts are permitted to send referrals via nhs.net mail, but as yet, should they do so, it's not actually clear how contractors would be remunerated for the activity, whilst payment for referrals documented on Farm Outcomes will be through a direct link with the BSA. So let's consider what community pharmacy is being asked to do in order to qualify for payment. Firstly, this is an essential service, so contractors must provide the service, but it is associated with an initial £400 setup fee. There are 3 separate stages for the service on receipt of a referral, for which partial payment for each section can be claimed. The remuneration for each stage is shown in the right-hand column. At the first stage, the electronic referral is received by the pharmacy, and the following actions should be undertaken as soon as possible, but within 72 hours of receipt. This does, however, exclude hours of the day on which the pharmacy premises are not open for business. Initially, a check for clinical information and actions contained within the referral needs to be undertaken. Details of what to look for are outlined in the DMS toolkit. This is the only part of the process at any stage which must be performed by a pharmacist. All the other 3 stages can be performed by a pharmacist or a technician. Next, there needs to be a comparison of the medicines that the patient has been discharged on and those that they were previously taking at admission. When necessary, any issues need to be identified with the referring trust or with a patient's general practitioner. Appropriate notes need to be made on the PMR or other appropriate record, including a note to ensure pharmacy staff are alerted to the need to conduct stages 2 and 3 of the service. The final part of stage 1 can be completed by any member of the pharmacy team. They will need to check any prescriptions for the patients previously ordered in the dispensing process or awaiting collection to see if they're still appropriate. Particular attention should be paid to the electronic repeat prescriptions, as these could be pulled down from the system sometime after the patient has been discharged from hospital. The second stage is when the first GP prescription is received by the pharmacy following discharge. The pharmacist or pharmacy technician will need to ensure the medicines prescribed post-discharge take into account of any changes made through the hospital admission. If there are any discrepancies or other issues, the pharmacy team should try to resolve them with the GP, utilising existing communication channels. Of course, any appropriate notes should be made on the PMR or other appropriate record. The third and final stage is to check the patient's understanding of their medicines regime. Usually at around the same time they collect their post-discharge prescription. This should involve a confidential discussion, either with the patient or the carer adopting a shared decision-making approach. When this takes place on the pharmacy premises, the consultation room should be used. But it can also be in the patient's home, via telephone or via video consultation. Where appropriate, other services can also be provided. For example, the new medicine service could be offered if clinically appropriate and of benefit to the patient. The process in this table represents the normal flow of patients through the service. However, on occasions, this will not be the case, and there are circumstances where the contractor is not able to complete all stages of the service. For example, when a patient is readmitted to hospital. In these circumstances, it would be appropriate to form only one or more of the stages and appropriate remuneration claimed. In terms of how many referrals hospitals are currently sending, this table shows how varied the current numbers are. What's really encouraging across the West Midlands is that we, with just a few exceptions, have a very high completion rate in community pharmacy. When TCAM was first piloted in Newcastle upon Tyne, completion rates were only 36%, so you can see that most of our completion rates are well over 70%, despite the current operational stresses on community pharmacy services. As an essential service, we are expecting completion rates to increase even higher, but it is pertinent to note that there may be reasons which are quite legitimate for rejection of a referral. For example, if you're not able to contact the patient at the contact number provided. In terms of where we are likely to be with respect to the numbers of referrals over the coming months, Acute Trust will have a sequin, a commissioning for quality and innovation payment from the 1st of April, which requires that they move towards referring between 1% and 2% of all their discharges through the DMS. Surprisingly, this only amounts to just over 70 referrals across the entire region on a daily basis, Monday to Friday. This, of course, is only an estimate, but when translated into the number of referrals each pharmacy across the region is likely to receive, it amounts to around 1 or 2 referrals for each pharmacy a month, not a number which is likely to cause concern to contractors at this stage. So finally, just to summarise, that the Discharge Medicines Service will be an essential service from the 15th of February. It's synonymous with transfer of care around medicines. Further information can be found on the LPC or PSNC websites, and across the West Midlands we'll be using mainly farm outcomes for the service. The NHS toolkit is actually now available via the PSNC and on the NHSE website. This final slide provides some links to all the documents I've outlined during this video. In particular, there is a frequently asked questions section on the PSNC website, which you might find helpful. Any further queries should be directed to your local LPC. Thank you for listening.